I'm going to talk about simultaneous analysis of voltage and force in human engineered heart tissues using genetically encoded voltage indicators. So our aim is to develop a predictive 3D in vitro analysis system for pro-rhythmic risk assessment by analyzing cardiac parameters, including action potential, calcium transient, and force. And this system can be applied in pharmacological toxicity testing, disease modeling, and maturation of EHDs. So we have previously established a system, automated optical testing system to analyze contraction force of the beating engineered heart tissues by making videos of these EHTs, and which are then analyzed by figure recognition software. And then these force peaks are generated, and from these force peaks we can calculate peak force, time to peak, and relaxation time. Afterwards, we established extension of this system to analyze calcium transient along with force. And calcium transient we can analyze by virally expressing genetically encoded calcium indicators, and these tissues expressing sensors are excited, and emitted light is converted into electrical signal by using a photomultiplier tube, and these calcium transient peaks are generated, whereby we can analyze peak fluorescence intensity, which is a surrogate for calcium transient, time to peak calcium transient, and decay time. And now we aim to establish a system to analyze voltage along with force, and by using the same method as we use for calcium, by using genetically encoded voltage indicators, for example, arc light, and then we can generate these type of voltage peaks. From these voltage peaks, we can calculate peak fluorescence intensity, which is a surrogate for voltage, and time to peak voltage, and decay time. We are using voltage sensor ArcLight, which is a single fluorescent protein-based sensor, and it is based on the fusion of a voltage sensing domain of Ciona intestinalis, which is a sea invertebrate, and this voltage sensing domain is fused to the fluorescent protein super ecliptic pH Lurion, which is a GFP analog, and movement of this voltage sensing domain alters fluorescence by repositioning a negative charge near the pH sensing region of a neighboring fluorescent protein. So what happened upon depolarization? The S4 domain of this voltage sensing domain, there is a conformational change, which then changes the position of strategically place negative charge towards the other fluorescent protein, and then the state of the protein is like this, that the fluorescence intensity decreases. 2D cardiomyocytes, you can see they are transduced with this sensor, and upon depolarization there is a decrease in fluorescence intensity. Transduction of 2D cardiomyocytes and EHTs with arc light sensor is showing decrease in fluorescence intensity during contraction. Yeah, you can, maybe this one video is not working. I hope it's working. Yeah. And then we determine the effect of arc light transduction on action potential in untransduced and transduced EHTs by performing action potential recordings by sharp microelectrodes. And we do not see any change in untransduced and arc light transduced tissues in terms of APD20, APD50, APD90, action potential amplitude, Vmax, and takeoff potential. And then to determine the effect of arc light transduction on repolarization inhibition in untransduced and transduced tissues, we used E4031, which is a repolarization inhibitor. We tested in transduced and untransduced tissues, and in both set of tissues, APD90 was prolonged after treatment with E4031 in both set of tissues, and the increase was more than 30%, although in untransduced tissues, this increase was not statistically significant. Force and voltage recording with this sensor showed moderate to large signal noise ratio. And the average peak of voltage, which is indicated by fluorescence intensity, and force showed a characteristic time delay between start of depolarization and contraction. We then validated our recordings by using pharmacological modulation of repolarization by using potassium channel blocker E4031 or potassium channel opener chromacalin. And E4031 showed a prolongation of the force peak and also the prolongation of the fluorescence intensity. Potassium channel opener, chromacalin, which efflux calcium out of the cell. It shortened the prolongation, it shortened the force peak, and also it shortened the fluorescence intensity peak. And then we assessed 18 compounds from SEPA classified list. And SEPA is an initiative which designed an assay for assessment of pro-rhythmic potential of new drugs with improved specificity compared with the Hurge assay. And this list includes many compounds such as some H1 receptor blocker, beta blockers, calcium channel blockers, sodium channel blockers, and the drugs which are known Hurge blockers at the clinical doses. And these compounds are categorized into these three categories: low TDP risk, medium, and high TDP risk categories. Before I present the result of these 18 compounds, I would like to introduce the pattern. So this upper panel represents force parameters, peak force, time to peak for force, and relaxation time, and then the average peak for force. And the lower panel indicates fluorescence intensity and time to peak fluorescence intensity, decay time, and average peak. And this data is relative to baseline and is also normalized to time vehicle control, except for average peaks, which are normalized to the smallest value in the data sets. And these are not normalized to time control. So sometimes there is a bit of discrepancy. So now I would present the first compound, loratadine, which is a low TDP risk. And you can see loratadine decreased force, and it showed no effect on other parameters such as TTP80 for force, relaxation time, fluorescence intensity, and TTP80 for fluorescence intensity and decay time. And similar you can see in the average peaks for force and fluorescence intensity. You can see a bit of tendency for the prolongation. So this compound adheres well to its classification into the low TDP risk category. And then the second compound is verapamil. Verapamil is a calcium channel blocker, and you can see it decrease the force and also decrease the time to peak 80% for force, and it should also decrease in relaxation time. And at the last concentration, EHTs most of the EHTs stopped beating, so there was no data for relaxation time. And similar results are depicted in the form of average peak. This black is the baseline, and then with increasing concentration, there is shortening of the force peak. And verapamil showed no effect on fluorescence intensity, showed a increase in time to peak, and showed a decrease in decay time. And this is also shown in form of average peaks, the shortening of fluorescence intensity. So verapamil is a calcium channel blocker, so therefore it if affects the calcium channel. Also, in addition to Hertz block, so you do not see any prolongation, rather you see a shortening of peak due to its effect on calcium channel blockage. And then is istamizole, which is H1 receptor blocker, and it is classified in medium TDP risk category. And istamizole showed a decrease in force, and there is some tendency for increase in time to peak AT, but it is not present at the highest concentration, and increase in relaxation time. And istamizole showed a decrease in fluorescence intensity, a large increase in time to peak AT for fluorescence intensity, and increase in decay time. And you can see in force peak, average peak, this effect in prolonged relaxation is not obvious because it is not normalized to time control. And then for voltage, we can see that at higher concentration of 1 micromolar, there is prolongation of the fluorescence intensity peak. And then next drug is domperidone, which is a dopamine D2 and D3 agonist, and this is classified as medium TDP risk drug, and it has shown decrease in force, no effect on TTP-80 for force, and increase in relaxation time. And here also we do not see prolongation of relaxation time in terms of average peak due to the fact that it is not normalized to vehicle control. Dopamine did not show any effect on peak fluorescence intensity. It showed an increase in time to peak AT for force, but it showed a large increase in decay time, which is also shown here in form of average peaks for fluorescence intensity. So this result is also related to the fact that it is classified in the medium risk category. So it has shown this prolongation in decay time. The next compound is Similide, which is a high TDP risk category, and it is a known Hertz blocker. It blocks IKR and IKS, and it has shown no effect on force, no effect on TTP-80 for force, and no effect on relaxation time, which is also depicted in form of average peak, and it has shown a decrease in fluorescence intensity and no effect on time to peak for fluorescence intensity, but it showed a large increase in decay time, which is also shown in the form of average peak at highest concentration in the form of prolongation of fluorescence intensity. Another high TDP risk drug is dofetilide, which is a known Hertz blocker and is used as a positive control in many studies. It has shown decrease in force, no effect on time to peak for force, and increase in relaxation time, which you can see in the form of average peaks for force. At higher concentration, there is prolongation of force peak. And this drug decrease fluorescence intensity and increase TTP-80, but it is not statistically significant due to this large variability. And it also shown increase in decay time, and which you can nicely see in the form of concentration dependent prolongation of fluorescence intensity peak. And then is this compound quinidine, which is a sodium channel blocker, and it is a high TDP risk drug, and it decreased force, showed no effect on time to peak for force, and it showed an increase in relaxation time, and it showed a decrease in fluorescence intensity, increase in time to peak AT, and increase in decay time, which you can nicely see in the form of voltage peak. So it is also we can see that it is we can monitor that it shows prolongation in decay time. That's for this category seems to be we can show the similar results as was shown in this categorization. And now I would summarize these effects. On particularly, I would summarize the effect on relaxation time and decay time. So relaxation time is for force and decay time is for fluorescence intensity, which is a surrogate for voltage. And we can see that the low risk drugs, they show minimal changes in RT and decay time, except for metoprolol and ranolazine. This verapamil and diltiazem, they are calcium channel blockers. So they, instead of showing prolongation, they have showed this shortening of the peak. And then ranolazine, and ranolazine is has showed this increase because it is a known Hurch blocker and also a sodium channel blocker. So therefore, there is an increase in relaxation time and decay time due to its Hurch blocking effect. And then medium risk drugs, they have shown increase in decay time in all of the drugs, while increase in relaxation time was shown only in 2 drugs from this category. And in high TDP risk category, we have seen increase in decay time in all drugs, but increase in relaxation time was only observed in quinidine and dofetilide and not the other drugs. So we can say that fluorescence intensity, which is surrogate for voltage, outperformed force readouts in detecting prolongation of repolarization. And voltage recordings revealed effects even when force failed, which is critical for early risk detection. And with this, I would like to thank my group and all the people who work with, and I thank you for your attention.
Thanks,
And yeah, now I would, yeah, you can take over, Marta.
Thanks a lot. It's great to see now that you can measure actually all the 3 functional assay in one model. So congratulations, first of all, from my side. Do you think that, of course, I mean, transduction for voltage indicators, so transduction of EHT might be actually not damaging but stressing for the EHT themselves? Do you think that, I mean, have you ever compared this method instead of using short microelectrode on the EHT using the same compounds? Would you see any actually difference?
So actually, this expression of this sensor in EHT is if you do the transduction during casting of these tissues, so these EHTs sometimes does not develop. So particularly in some cell lines are more susceptible and some not. So therefore we transduce these EHTs when EHTs are fully developed. And also these tissues, they do not survive for long, like for months, as I have seen with the calcium sensor. With calcium sensor had really no effect on ESTs, but this sensor had some effect. So we have a window of probably 2 to 3 weeks to do the experiments, and then ESTs start to decline in force.
But have you ever tested any other voltage indicators to see if it's...
Yeah. So actually, we tried many voltage indicators, but due to their low signal to noise ratio, we was not successful. We have tried ASAP1 and some others as well. So this voltage sensor has the priority in terms of better signal to noise ratio. It's kind of 20% more than ASAP1. And this sensor is shows it has slower kinetics as compared to other sensor, but these kinetics are sufficient to monitor the voltage in cardiomyocytes. And for example, in neurons, you maybe need sensor with the really high on kinetics. So for our studies, it was only with this sensor we was able to record any fluorescence-based voltage, and others we could not.
Okay, thanks for that. Um, so there is a question from the audience. Does light from the entire tissue surface reach the PMT, or do you use shutters to focus on a smaller specific area of the tissue?
So we use only PMT. I do not hear the what was the in between the sentence.
So does light from the entire tissue surface reach the PMT, or do you use shutters to focus on a smaller specific area of?
Ah, yeah, okay. So actually, we initially used like a 10x objective to particularly focus on a part of the tissue, but then there was a lot of motion artifact, and then we used 2x objective, and still then there was a motion artifact. So we then increased the region of EHT, and now the light from the whole tissue is being observed and then converted by PM2 into electrical signal.
So the complete. Okay. And why do you actually think that the force sometimes then lack to be predictive of the
Ah, okay. So actually, force is like different second messengers are involved, and force is like the end outcome. Therefore, there are a lot of compensatory mechanisms due to which we do not see effect on force, but only in voltage. And also there are expression of different ion channels in cardiomyocyte is different than the primary tissues. For example, it is known that hips express more calcium channels as compared to sodium channels. So therefore, sometimes it is compensated, and then we do not see any effect on force, but we see effect on voltage.
Okay. Yeah, so at the end, in your opinion, it's important to have like all the three functional readouts.
Yeah, so actually now we cannot use the calcium and voltage together, but only for the moment we can only use force either with calcium or either with voltage. Because this calcium sensor we have established and voltage, they both are GFP. They both use GFP setting. So we still need to find out a calcium sensor or voltage sensor with the different excitation settings.